focusing on reforming healthcare, trying to put something together that is comprehensive and works better for more people. What we have now is two different areas: how healthcare is financed and how it's delivered. Many people in this room are working in the area of finance for a system that is publicly funded, accessible, universal, fair and equitable, and affordable. And more people are working with us all the time in that effort. But tonight we're here to talk about the delivery part. And as Oregonians, we are in the lead in this area. Our governor, Kitzhaber, who happens to be a doctor himself, has instituted this transformation among Oregon Health Plan members. We're going to show how the Coordinated Care Organization works, brought to you by a group of local actors. Secondly, we're going to share some stories of OHP members, that's Oregon Health Plan members, about their experiences. And third, we're going to recognize achievements by the IHN CCO, that's the Intercommunity Health Network Coordinated Care Organization, our local coordinated care organization, in some key areas, as well as take a look at some challenges that are still to be overcome. The CCO is a legal entity. It's certified by the Oregon Health Authority to coordinate physical, mental, and oral or dental health for OHP members. There are 15 in the state of Oregon. Ours consists of Lynn, Benton, and Lincoln counties. It's called the Intercommunity Health Network Coordinated Care Organization, and contracts with various providers to give the best care and the most coordinated care around a patient, around a particular patient and that patient's needs. There are 55,000 members now in our Lynn, Benton, Lincoln Coordinated Care Organization, 18,000 of whom have joined in recent months. So that gives you some idea of the amount of growth and the challenge that's going to be for capacity in other areas around the Coordinated Care Organization. Transformation is designed to move from an episodic acute care system that becomes somewhat fragmented or very fragmented toward a preventative system based around wellness. It takes a lot of time to do this, to change from one way of doing things to another way. And as I mentioned earlier, it's been 100 years since people first started working on some aspects of this. I hope it doesn't take another 100 years to do this, but it's certainly going to take more than just a few months. We can't expect overnight success, but what we're talking about tonight is 2 years success. It's been 2 years since the inception of this organization, and we're having a birthday party for this organization, and we'll talk about some of the good things that have happened during that time, and maybe some of the things too that are left to be addressed. Mid-Valley Healthcare Advocates, who is the kind of the major sponsor for tonight's event, is part of HCAO, and is dedicated to bringing changes to the finance system, as I mentioned. The CCO is about delivery. These two are interdependent. You really can't have one without the other. We need a better system of financing healthcare. We need a system that doesn't depend on gold and platinum and lead and these different kinds of schemes or scams to sell people something that may or may not cover them when they get sick or injured. We need something that's universal and seamless and accessible to everybody who lives and works in Oregon, and that's what we're working on. Also, we need to make sure that a patient's primary care physician and team is the center of the medical activity around that patient. And that's what the Coordinated Care Organization is tasked to do, and is indeed working on and making it happen. So these two things are interdependent. We really can't have one without the other and go forward with a successful healthcare system in the United States and in Oregon. I'd like to introduce Dr. Kristen Bradford, who is the medical director of the community health centers of Benton and Lynn counties. She's going to share some stories of actual people. These are Oregon Health Plan members who have been involved in the new coordinated care system and who have some things to share. So please, Dr. Bradford, if you would, I'll let you tell us about this.
Thank you, and thank you for being here tonight. I'm really pleased to be a part of this celebration. I'm feeling really grateful to be practicing medicine in the state of Oregon at this point in time. As Ron introduced me, my name is Kristen Bradford, and I'm a family practice physician and the medical director for the community health centers in Benton and Lynn counties. We have 4 clinics, 2 in Corvallis, 1 in Lebanon, and 1 in Monroe. And I'm feeling even more grateful to be working in Benton County, where I'm part of an organization that is implementing the patient-centered primary care home model. It's definitely a challenge and a transition, but it's one that is taking us where we need to be and where I think providers in the healthcare system really want to go. We're changing from a model that's centered around the provider, with everybody there to help the provider or the physician, taking the provider out of the middle of this picture and putting the patient in the middle, and having everybody within the organization around the patient to try to help them. I'm briefly going to introduce some videos because I think that the patients do a much better job than I do telling their stories. But I would just like to share a couple of brief stories related to the changes that I'm seeing because our state has chosen to expand Medicaid to tens of thousands of patients, tens of thousands of our community members in the state. We, within our organization alone, have expanded to take on thousands of patients who were not insured until they became covered with IHN and the CCO. Some really brief examples: patients who have diabetes but haven't been able to afford their insulin for years, and so their diabetes is under control, now are able to get in and have regular care, get back on their medications and their insulin, and control their diabetes. Woman who came in to get her tetanus and pertussis booster because she wanted to protect her grandchild, her new grandbaby, from whooping cough, found out that she had high blood pressure, and we were able to diagnose it and treat that, get her blood pressure down, and lower her risk of stroke in the future. People who would maybe have what seemed like a minor illness or injury, but have to go to the emergency room and incur thousands of dollars of bills just to be seen and checked out, and probably to go home being told to put ice or heat on it or drink lots of fluid, now aren't having to go into debt to be able to get routine health care. Those are a couple of brief examples. I would love to share more later, but I think the patients do a better job of telling their own stories. So I'd like to introduce a couple of videos that some folks have been involved in putting together.
When I got laid off, I lost my health insurance, and there was some kind of a program that I could have paid a whole lot of money to maintain it, but it just wasn't reasonable for me to put that much money out to keep health insurance. I was healthy, and for years I said my health insurance was my bicycle. I stayed healthy by riding around, but I hadn't seen a doctor in a long time. I'm getting close to being 60, and it's a concern. I feel much better now that OHP has offered this program where I can sign up. I get health insurance. Great. I'm still not needing medical care. I'm not in terrible condition, but now I've got a system that will help me to stay that way, and I feel a lot more comfortable knowing that I've got a fallback. If I were to get sick, insurance has got me covered so that I'm not going to be just turned out on the street.
I just want to say that I went through 3 phases in the medical community, being insured, fully insured, and then I went to no insurance and self-pay and had to have surgery. And now that I got back to Corvallis, these people showed up, filled out the paperwork, and within 2 or 3 weeks I was fully covered, and now I'm back under my doctor's care and taking care of all my medical needs. He's awesome, and it's really nice to know that there's a lot of ease of pressure of not having to worry about those kinds of things now. The first injury happened when I was insured, and that was real easy. And the second injury happened when I was uninsured, and that took me almost 3 months to find a doctor. That was very difficult. But now I have to just, knowing that I'm covered now, it's like I still have issues with this knee, but now I'm getting the care that I need. And in fact, you know, I need like a new leg brace and therapy and all of that. So it's going to be great to take that to the next level. And that's really cool. That gives me like one less thing to worry about. Yeah. So I'm really grateful for the Oregon Health Plan doing what they did this time around. It's real easy and helpful.
How quickly are you able to get care when you need it?
I'm able to quickly get care, just basically as soon as I decide that I'm ill or need to see a physician, I call the Benton County Health Department, make an appointment, and they see me as soon as they can.
How well does your care seem to be coordinated among the various caregivers and administrative personnel who meet with you?
Well, I have a physician that I see every time that I come here, but if he's not available, then I see somebody else, and they have a computer system where they store my information, so it's really smooth. It's a system that works, and everything's kind of connected, and as soon as I come here, I kind of know where to go.
Are you able to compare how your care is now compared to 2 years ago, or how the clinic handles your care any differently?
Well, now that I have OHP and that I'm able to come to the department, I feel as though if I ever need to go to a doctor, I'm not hesitant about it. I make an appointment as soon as I feel like I need it. And so I just feel like a lot more flexible in that way. I fall into the low income bracket, and so before I didn't feel that I could afford healthcare, and that if I needed it, then I could just tough it out or, just go very minimally. But now I feel like I can go if I need to.
And I would just add one other point, a big difference that I'm seeing with the increased number of patients who are covered with OHP is the accessibility of preventive health care. So routine mammograms, pap smears, vaccines, colonoscopies. People don't have to put those off for years or decades, waiting until they can come up with enough money to pay for it out of pocket. They'll come in and do it right on schedule. So that's really a big benefit to this as well to our patients.
Thank you, Dr. Bradford. At this time, I'd like to introduce our panelists who will take their places on the stage and fight for the microphone. First of all, Kelly Kaiser, the CEO of Intercommunity Health Network, Oregon Care Organization. And please make her welcome, Kelly Kaiser. I'm going to have Kelly introduce some of the board members who are present here tonight.
So thank you for having us here and celebrating the success of the coordinated care organizations. Commissioner Jay Dixon sits on our board of directors, and he is here with us this evening. And Dr. Larry Eby sits on our board of directors, and he's here with us this evening. And hopefully, if anybody else snuck in that I didn't see, I apologize. But I think those are our two members that are here today.
Thank you. Next is Sherlyn Dahl, who is the director of the Federally Qualified Health Centers for Benton and Lynn counties. Please make her welcome. Dr. Kevin Iwanchina, who is the Vice President of Medical Services for Samaritan Health Services. Welcome, Dr. Iwanchina. And Dr. Larry Eby, who is the chair of the IHN CCO Community Advisory Council. Dr. Eby. And Judy Sundquist, who is Master of Public Health and Registered Dietitian and Nutritionist, is here tonight. Actually, Judy created this artistic page that you see, or had a big part of it. And I'd like to call Judy to come up now and kind of explain what you're looking at. Judy Sundquist.
Good evening. You know, in my later life, I've become a graphic artist. So you'll see on this back of the agenda is something we came up with to visualize some of the measures, or what they call metrics, that the CCOs have had to address. So let me just say that we are really very pleased and encouraged by the performance of IHN CCO with the measures, and we have just selected a few. So I'm not going to give you a whole course on all these measures because it's really quite involved, but there are the 33 measures that all of the CCOs had to address, and it's really quite a landscape and quite a lot of data and work, and it's just horrendous. So anyway, so you know, we on the back of this sheet here, you have a few that we've highlighted, and let me just mention the selection process was not data driven per se. We looked for sort of a breadth of physical and mental health measures. I don't believe there are any dental health measures on these metrics. Is that correct? Not yet. Yes, that's what I thought. Okay. So we were looking for ones that were pretty significant, so that entered into our thinking. We also looked at measures that IHN ranked in the upper half as compared to other CCOs. So it's also, you know, it's always a good idea to compare apples to apples, and so we were comparing IHN to other CCOs. And we also kept in mind how major this healthcare transformation is. So with that, we selected these particular measures. I do want to just mention a few specifics here. You know, these measures are really developed, you know, by the state and the federal government, and it's really quite a comprehensive process. So, and they're quite studied, and they are reflective of really where we're going with healthcare transformation, something called the triple aim. How many are aware of the triple aim? Is that a term that's familiar? Oh my gosh, quite a few. So the triple aim is, it's about improving the care for patients, it's about getting outcomes or better health for the patients, and it's about reducing cost. So these metrics really are in the spirit of that triple aim. I also wanted just to mention that these physical and mental health services that are being measured are related to the Oregon Health Plan members at this point in time. So again, there are 33, and right what you're seeing on this sheet is we only have 7 listed. So I'm hoping that the panel will discuss, either they'll comment on these 7 that we picked or talk about the others as well. So let me just mention, so the first one we have listed here is access to care. And I really think, you know, the vignettes that we just saw on the screen here really reflected access to care and really how very important that is. So what we saw with IHN was a 5% improvement. Let me mention on these improvements that comes from a 2011 kind of baseline, and it really kind of covers a full year of 2013. And as I just want to mention again, there's a whole landscape of things they're working on. So here's a major area, very important one, access to care. We saw improvement. I'm going to tell you what that means, access to care. Percentage of patients, and those are adults and children, who thought that they received appointments and care when they needed them. So then the second one here is immunizations for adolescents, that improved by 16%. And that means percentage of adolescents who received recommended vaccines before their 13th birthday. Now, the third one is patient satisfaction, that improved by 14%. That had to do with the percentage of patients, again, adults and children, who received needed information or help and thought that they were treated with courtesy and respect by customer service staff. Fourth achievement, this whole group here are all achievements. It's medical assistance with smoking tobacco cessation, and that improved by a whopping 68%. And that has to do with the percentage of adult tobacco users advised to quit by their doctor. I'm not sure where that is with e-cigarettes, but hopefully they're doing that as well. And then we get to the fifth one, is developmental screening in the first 36 months of life, and that improved by 200%. Very excited to see that improvement. That has to do with percentage of children who were screened for risk of developmental, behavioral, and social delays. That's using standardized screening tools for 12 months preceding their first, second, and third birthdays. So that's really 3 years, 3 points. So we're really quite pleased to recognize, and as I was saying, these 5 that we selected, IHN really showed at the top half compared to all the other CCOs. So they're really showed some status of improvement. There are a couple of challenges that we selected as well. And again, remember we had a landscape of 33. So, as you know, mental health has been incorporated here, and that is really kind of a new arena to have that kind of coordination in physical health care. So that's an area that's was requiring some ramp up. And the first one we selected was follow-up after hospitalization for mental illness. IHN on this one and also the second one fell in the lower third as compared to the other CCOs, and so that's what caused us to pick these. And again, we think that there can be improvement because these are new areas. So again, getting back to the follow-up after hospitalization for mental illness, that's the percentage of patients ages 6 and older who received follow-up with healthcare provider within 7 days of being discharged from the hospital for mental illness. So it's really quite a tight kind of measure, or what they call a metric. The second challenge area that we selected had to do with patient-centered primary care home enrollment, and we did hear reference to that tonight. That's the percentage of patients who were enrolled in a recognized patient-centered primary care. And again, these are 2 areas that we're looking to have IHN continue to develop. And we're very hopeful that they will continue with all their achievements and then pick up the areas where there's challenges. So we're really quite pleased with their performance overall.
Thank you, Jim. At this time, I think we're going to have each of the panelists kind of respond to the information that you've been presented and that you see there. I'd like to direct your attention, the panelists, I'd like to direct your attention to Loretta Rivard, our timekeeper. She's sitting right here in the front. Loretta has got a 2-minute sign and a 1-minute sign, and the 30-second sign. So just, she'll be waving that at you, but we want to try to keep on track. So let's just go down the line, and panelists in your area of expertise and understanding about this information, and also just about your job in general. You might want to explain a little bit about what your part is in this transformation. So since we have one microphone, it's going to be your turn.
All right, well, thank you. I don't think I'll start by describing my job. That might make you all a little bit bored. But I first wanted to thank everybody for, especially Mid-Valley Healthcare Advocates and the community for having this celebration tonight. We're incredibly honored about the support that we're getting within the community and from our members and our partners. This is all about the members and making sure that we can do whatever we can to serve them as best as we can. So that's really our main focus. I'm actually going to defer to Dr. Ewan Chinna, who is our Chief Medical Officer, who has a lot of information around the specific metrics to answer some of the questions around the metrics themselves. I will say from a more of an administrative operational perspective, of the 33 metrics, there's only 17 that the health plans or the CCOs are specifically accountable for. The rest the state manages and tracks. So we've been fortunate enough that we are not, of course we're responsible in terms of patient delivery for everything, but as the CCO in terms of our contractual and what our main focus is, it's really around 17 of them. So fortunately that narrows the pot a little bit, so we can put a lot of energy and effort into those. And I will defer to him in terms of talking about some of our plans around addressing those, especially that are in the challenges area, because those are certainly something that we want to work on improving on. I did just want to call out a few things that I think have been great successes. Over on the table is a summary of our 2 years. And again, it doesn't seem like it's been that long. It's been a wonderful ride. I have to thank all of our partners in this in terms of Benton County and Lynn County and Lincoln County, the Council of Governments, all the providers, Samaritan Health Services, the Grouse Clinic, the independent providers through Quality Care Associates. We have alcohol and drug providers and dental providers and mental health providers, and everybody is really sitting at the table and really working together and collaborating together to make sure we do the best thing we can for our members. And we had a public meeting with our board a couple weeks ago, and I think Mitch Anderson from Benton County was there, and we were joking that we see each other many times a week in terms of talking and having meetings about what can we do to make things better. And that's not something that used to happen. We did not used to have meetings and coordinate at all that much. And so that's been a great opportunity and a great opportunity to meet new people and find out how things work in different places and make sure we can bring together whatever the best way is, regardless of whose way, to take care of our patients. So it's been a great experience. A few things to point out that again are on the table over there. One of our big accomplishments in the last year has been the integration of dental. So in the legislation, mental health and physical health were the initial pieces that were being brought together under the coordinated care model. And dental was coming in at a later date, and so we did bring in dental October 1st of 2013, and so we are contracting with 4 dental plans that serve members in Lynn, Benton, and Lincoln counties, and working on integrating them into all of our panels and our processes and our communication and our stakeholder groups and our quality groups, and so that's been very exciting. Again, that's only been about 8 months or so, and we're still working on how to integrate all those people, but that was a major accomplishment that we're very proud of. I think all the work that our Community Advisory Committee has done, which you'll hear, I'm sure, from Dr. Eby, has been incredible in terms of our Community Health Improvement Plan and our focus on our members, and this has really been people volunteering their time for more than 15 months, some of the members, community members, to really see what can we do to improve the health of our OHP members. So that's been incredible. We are also very happy that we did submit our first transformation report to the state in July. Again, part of the transformation in the legislation around the coordinated care organization was how are we going to transform care and what are the things we are doing all together to do that. So we successfully submitted that summary to them. So that was a major accomplishment that we're really excited about. One more piece, and then I'll turn it over. I'm not getting the sign yet. Is that we've worked really collaboratively with all of our stakeholder partners around grants, and we're pretty excited that we've been able to bring in more than $5 million of grants into Lynn, Benton, and Lincoln County in public health in a whole variety of different ways to make sure we're serving our members, and not only the main focus of course is the Oregon Health Plan members, but as we transform care around that population, best practices come out, and we would of course apply that as a delivery system to any members in terms of what makes sense for the patient. So a lot of great energy, really proud to be part of this and part of this community and everything that everybody's doing together. And again, just want to thank you for putting all this together. And I know many of you in the audience I recognize as continuing to donate your time and energy to help us continue to improve this. So I just wanted to thank you for that.
Thank you. I'm also pleased to have the opportunity to talk with you tonight. Dr. Bradford did a great job of sort of highlighting the changes from a patient perspective. And what I wanted to do tonight was make a few comments from the organization perspective and sort of what the change has meant for us within an organization that's providing care. And the mission of a federally qualified health center has always been about addressing access. And so it's really nice to be in a place and a time where we're starting to feel we have partners and people who are also thinking about the same things that we've been thinking about for years. I used to worry a lot, and my worry was coming from a sense of scarcity. All the people out there that didn't have insurance, who had this unmet need, how can we help them? How can we make decisions about, how can we be available to them and not have very many resources to do it? Today I still worry, but it's coming from a worry about capacity, and that is how do we grow to be able to meet the needs of the people who now are ready and able to come and get their health needs addressed. So some of the things that we have been doing are expanding our hours. We have more evening hours. We've added a provider. We're doing those things so that we can be as available as it's possible for us to be to serve the folks who need access to care. Patient-centered primary care home has always been our model of care. The only and best way, in my opinion, to serve vulnerable populations with complex and multiple needs has been to have a team that is able to address the multitude of issues that we come. And so, because we've been coming from that place for so long, today I feel like we're a leader in implementation of the patient-centered medical home. And that's sort of nice to be able to finally be in a place where people will ask us, how are you doing it? How's it working? What help? Just to be able to provide that input is really nice. The integrated model has been really important to us. Mitch Anderson and I, a long time ago, felt that we knew change was coming, we knew health reform was coming, and we felt that the integrated model, where we really brought together the resources that we had in the building of primary care, mental health, public health, we've added dental since then, was what we wanted to promote across the whole organization. And that has been a long journey, and we haven't arrived, but we've come a long way at really making our services feel seamless to people, instead of making people figure out which one of our services to use. So that's been great. One quick comment from our board. Our board wanted to provide a few comments tonight. A federally qualified health center by mandate has 51% of our board are people who use our services. And so they have long recognized the importance of patient voice in making decisions and in governance, and they wanted to recognize that. There's a couple of things that still need work, and we're transforming how we're thinking about delivering care, but we've only just started to talk about how we're going to transform payment. And until we really do that, progress is going to be slow. So we still need to work on that. And the other area is around patient engagement. We've been trying to reach out to people who have been newly assigned to us. We made a few phone calls. Some people who are feeling healthy today say, well, why are you calling me? They're absolutely not used to thinking about healthcare in a proactive, preventive way. And that's another message that I think that all of the advocates can really help us get out there, is to help to promote the understanding and the importance of being engaged in your healthcare and thinking about it before you have some serious health issues that you need to deal with. So it's a great time to be in healthcare. It's scary, it's challenging, but if you like that stuff, which I happen to do, it's really fun.
So good evening. It's good to see so many familiar faces out there, people that I have seen in my clinical setting, people that I have lived by as a neighbor, and many familiar faces that I have worked alongside in team meetings, in care coordination meetings at the state, and really you from the community that we have been blessed to live in for so many years. First, I wanted to put a disclaimer on my initial title when I was introduced. And it is true that a few years ago I did hold the title of Vice President of Medical Affairs for Samaritan Health Services. And when an opportunity came to work with Kelly Kaiser, IHN CCO, and I did want to point out Kim Whitley as our Chief Operating Officer for IHN CCO right there in the corner, and become part of the CCO movement in the state of Oregon, that's when my role and title transitioned. And so now my title within the organization is Chief Medical Officer of Intercommunity Health Network CCO. I still see patients from a primary care perspective. And I wanted to put a little bit of a spin on the skit that you had seen earlier and put my take on it. And Dr. Bradford and I are kind of the same age, but she's still a few years younger than I am and much more attractive. But when Dr. Bradford and I went through medical school, we chose family medicine. We chose primary care because it was our calling. We were very relationship-driven people, and that's what relationship-driven people chose as a residency. Then what happened? We went through our residency, and we all thought we were going to practice medicine in the second model that you saw, the patient-centered medical home model. But we graduated into a medical system that had already been put in front of us. And it became the rat race, the spinning of the hamster wheel. And so I'm not stating that all physicians that entered primary care want to, or are embracing of the primary care patient-centered medical home model. Many of us are, because that's what we chose as our calling. But we only entered the system that had already been created. So changing that system from the very first model that you saw to the second model that we all want will take time, and it will take energy, and it will take coordination of the care. And I do want to say, on perspective of us as consumers as well, I think we as consumers are going to be needing to be comfortable with the concept of a team-based care approach. For years, we've had the luxury to have a one-on-one relationship with a physician and as a patient. Now, because of the complexity of healthcare, we're going to need to establish that same trusting relationship of care, not only with the team physician as the lead, but the whole team. And so there may be times when I will need to access my medical services by a phone call, and that will be okay. There will be times I need to access medical information by an email or a text message or phone call with the nurse care coordinator or the medical assistant, and that will be okay. There will be times when I may need to access services from a nurse practitioner or a physician assistant that's part of the healthcare team, and that will still be okay. And then we need to hopefully reserve our highly trained physicians for the most complex care and allow those physicians be those team leaders for the whole healthcare team. So our onus as consumers of healthcare as well, we're going to need to change our perception of what is realistic. That we may need to get away from that one-on-one with the physician each and every time, but know that we have a whole healthcare team of people, inclusive of behavioral health, inclusive of mental health and psychologists, and this whole team actually is giving us more resources and services than that one physician could do on a one-on-one perspective. I'm now going to switch a little bit and talk about one of the achievements, and then one of the, instead of challenges, I'm going to say opportunities, because I like to look at things as the positive. And one of the achievements that I was really, really excited about, and this will go back to my previous title of Vice President of Medical Affairs for Samaritan. Several years ago, I championed the cause to ensure that our 5 hospitals in our 3-county area and our Samaritan-affiliated clinics and practice sites were all tobacco-free. I'm a staunch tobacco-free person. And when I say tobacco, that is inclusive of e-cigarettes. And we know that if you are a smoker and you become a non-smoker, outside of everything that we have created with modern day medicine, immunizations, antibiotics, surgery, it is still the number one best thing that you can do for your own personal health is if you are a smoker, that you have become a non-smoker. Smoking is related to so many of the top number of diseases in our nation. So I'm really, really excited that we were able to improve our target so robustly. And there's going to be more improvements. Through our collaboration with our counties and our county health departments, we were the major recipient of a Mid-Valley and Coast Tobacco Initiative. And so we are going to be looking at becoming that resource center, that clearinghouse of all cessation aids that are available to the population to help assist them with their tobacco cessation quit dates. We know that when you want to choose to give up tobacco, that is not one size fits all. It is many, many times and many approaches to trying to quit tobacco. So I'm really excited about our CCO and our collaboration with our counties to leverage grant opportunities to give more funding for programs such as these. One of the biggest opportunities that I've already seen improve from when this data was collected, and that is the follow-up after hospitalization for mental illness. And I bring this one up because of the need to look at data and how we report on this data, and how this data is then reported to the state, and how it's then in turn reported back to the CCOs. And we know that our colleagues in mental health have been trying their best to ensure that if a patient, if a member in our community was so severely ill enough that they needed to be admitted to an inpatient mental health unit, that it is very important to ensure that there is a follow-up visit within 7 days after their discharge. And that's what this metric is all about. We know that the intent from the inpatient mental health was there, but I'm going to take us back to the target year of 2013. What else happened in our healthcare system, Samaritan, in the year 2013? We went from a basic electronic platform of Meditech, which still had a lot of paper components, to a robust system called Epic. So how many in the audience have heard of Epic? Epic is an electronic medical record. And our entire hospital system, 5 hospitals, inclusive of our inpatient mental health, transitioned to this new electronic medical record. There was a huge learning curve when it came to implementation of Epic. And it was also due to this implementation of Epic that we found we were not able to robustly track enough this follow-up visit after a discharge from the inpatient mental health unit. What we have done since then is ensuring from the discharge component, the discharge planners of the inpatient mental health, that by the time they're even admitted to the inpatient mental health unit, they're already looking at the discharge date in follow-up. Ensuring also that it doesn't always have to be a mental health provider that they have to be followed up by. It could be a member of their primary care team. So as long as there is a follow-up by somebody, and that follow-up by somebody then follows through with a charge that is submitted that we then, on the CCO side, can track robustly. So we're already seeing some improvements for 2014 and above and beyond. But I know specifically that the challenge with data and how you report that data and how you track that data is often one of the underlying problems and opportunities with how to report more robustly on these metrics in the future. I'm going to leave some of the other selected achievements and challenges because they may come up in the question and answer components that are going to be following afterwards. But I again have to echo how excited and pleased I am to be working in a CCO and in the state of Oregon at this time. I love the practice of primary care. I believe that primary care centers completely with what we need to achieve within the CCO and for all Oregonians. And we're finally at a time where I can sit alongside my friend Charlene, where previously we were more competitors. When I carried the title of Vice President of Medical Affairs, I didn't want to collaborate with Sherilyn because it was a business model of care. And we were all after the same person for a business model of care. Now it's turned around for a care model, and we're able to be at the same table talking about best practices, how we will implement best practices across a whole 3-county region. And from my perspective, in talking also with mental health colleagues that I hadn't had the chance to talk with before, I really am excited about the future of the health for all Oregonians. Right now we're talking about the CCO, and that really is the Medicaid plan. But in our discussions with primary care, patient-centered medical homes, in our discussions at our quality management committee for the CCO, we're not talking about creating 2 tiers of service delivery. We're talking about if we can adopt this for our CCO members, we want all of our primary care clinics to also be looking at the same metrics for everybody that comes through their door, irrespective of the insurance that they carry. So kudos to Oregon, kudos to us.
Due to the generosity of the timekeeper, I don't have to say anything because the time's all taken up. And there's no time left for me, so we'll go on to the next topic.
We know you better than that.
You know, Queen Elizabeth and I have something in common. We're both over 80, and we get a lot of credit for things that we don't do that everybody else does the work for, and that's pretty much what my position as chair of the CAC is. There are so many good people out there doing a lot of really hard work, productive, good work that I just sort of watch and cheer and get to give speeches. I don't know if they're flowery, but anyway, some kind of speeches to talk about it, so that's what I'm doing tonight. A little over a year and a half ago, after I was elected the chair of the Coordinated Care Organization, which is by the way, the Coordinated Care Organization is the voice of the people in terms of bringing the concerns of the people to the table, and let's try to, in 2.5 minutes, maybe a minute and a half that I have left, say as much as I can about that. So anyway, I met with Kelly, and for my first meeting, he said, okay, Larry, by June 30th, 2014, your organization have to come up with a community health improvement plan for the 3 counties. And you don't have time to do it from scratch. You got to take what material that's already there and produce this because that's what the state wants. And so anyway, I took her seriously, and after that, we did a number of things. But one of the important things were that we hired a coordinator. I don't think Rebecca is here. I can't see her anywhere. Rebecca Flowers, who I want to give tremendous credit to for helping us through the weeds. I was going to wear my hat tonight. I have this cap that says, "I'm their leader. Where are they going?" Anyway, she should have worn that hat, actually. We actually took Kelly's advice, but we didn't really follow it. In that we started to some extent from scratch and built a CHIP, a Community Health Improvement Plan. We did use materials that had already been done by the counties and by other organizations, but we also, by different means, and it would vary from county to county, processed through in terms of trying to say what our counties needed. And so our organization is, we have 3 separate county advisory committees, and they meet sometimes twice a month. Now it's pretty much once a month. And that's where the really hard work was done in terms of coming up, first of all, with health improvement areas. And I think we had something like, we started out with something like 45 different things. We condensed those into 4 health improvement areas, those being access to care, behavioral health, chronic disease, and maternal and child welfare. And under those, we have 14 goals, I think, and under each goal, we have a number of strategies and then activities to address those strategies. It is interesting how those results fit with the metrics and so forth of the CCO. So we weren't at odds with each other. We were cooperative. We stressed that we are there to cooperate with each other, and I think we've done a pretty good job of that. And so I'm just going to mention a few names here of people that are here that are part of this. Joe Czar from Benton County was in part of this, and on various levels. Melinda Moore and Nick Knowles from Lynn County are here. They chair they're co-chairs of the Lynn County Committee. Chairman Mao back there is on the CAC. I know her, and I know I can call her that without needing something. And Bill Bushcott from the state he was just a huge resource for us in working in this. Now, I want to say one more thing, and that is that in this thing of we need of challenges in the primary care, patient-centered primary care enrollment, we started out ahead of everybody else. And so we changed very little. The rankings have to do with how much change is. The reason we're behind all those other people is that they were doing a crappy job to begin with.
I was going to point that out, but I'm so glad.
And they didn't have to do much to be a whole lot better. And we had to work our tail off to move 1.5 percentage points. But we are now at 87.6, and that is the second highest in the whole state. So that's not I think that's hugely important because that's really the secret, as we've heard from the others, of getting done what.
Thank you, panelists, for that setup and introduction. Now we have some questions, and we're a little bit late right now, so we'll try to get the questions done quickly and with alacrity. So again, we're struggling with one microphone, so I'll just kind of do the little dance here, ask the question, and then let whatever panel member wants to take this, take it, and I will refer you to Loretta, who she is holding these things up. How does the money flow different than how it used to? Does it all go to county health departments?
Mitch? No. So I'll take that one. So the difference is that historically, the physical health dollars would flow through the physical health delivery system, which it was IHN back there in the physical health. The mental health dollars in the state of Oregon would flow through the county mental health departments. And then the dental dollars flow through all the dental plans. So as an OHP member, you might have 3 ID cards. You'd have a card for your physical health, a card for your mental health, and a card for your dental health. You'd have 3 different member handbooks, you'd have 3 different phone numbers to call. So that's how things were before August of 2012. Part of the coordinated care model is that the coordinated care organization, which in this case is IHN CCO, all of the dollars, all those 3 financial streams come into the IHN CCO now, into one entity, who's responsible, as our skit showed, and all that we've heard, for making sure that that coordination happens. Part of our model has been to not disrupt the services and the relationships that were already in place. So we pass some of those dollars through to the counties to cover mental health things. We are passing dollars back to the dental plans to cover what their area of expertise is. But along with all those comes some expectations from all of us around coordination and collaboration and making sure that happens. So the money has changed the way it flows with the goal of collaboration and coordination around the patient.
What do you think of using medical scribes, perhaps students from the medical school in Lebanon, to take notes for doctors so they can spend their time listening to patients instead of typing on their computer?
Yes and no. Medical scribes are not an easy answer, but they could potentially be an answer. And it always depends on the type of medical scribe that you may be working with. Now, medical students understand the medical language and the lingo that I am talking. But if we really want to transform care, I, as a physician, have to talk to patients in a health literate way. And that means living room language. So, do you need a medical scribe to just dictate things in living room language? Maybe not. But could you utilize a medical scribe to ensure that the basic elements of your plan of care with the person sitting in front of you are fully implemented in the electronic medical record? And that could be a role for them. I have seen medical scribes work well in some settings and not so well in others. And think of a situation where you may have a very specific reason for going to see your healthcare team. And it's something that you are very uncomfortable discussing even with your healthcare team, your physician. If you have a medical scribe, a third person, then in the room at that same point in time with you, it could be a possible barrier. And what the CCOs and healthcare reform is all about is removing as many of the barriers as possible. So I feel that scribes could have their place in very busy settings like an emergency room, where it is so busy that you need somebody to just document the plan of care that you are implementing at that same time. I do wonder about the role in a true primary care medical home where the relationship is the very essence of importance. And what would a scribe do to that relationship?
Are there sufficient numbers of providers for children and teens' mental health in our community?
Well, I'll just say that no, I think that's a tremendous opportunity and one that everybody's looking at, and I'm sure everybody has some thoughts on.
Lately, we've had a lot of very good and deep discussions in our county about the need for suicide prevention and really focusing on mental health needs in our adolescents. So Dr. Fisher, very well-renowned child psychiatrist in our area, we are so fortunate to have her collaborating with us as a CCO, and she is helping us with some pilot projects to bring more services for mental health to our adolescents, our youth. We do know that this is an area that is vastly underserviced right now. And part of it is because we have not created, historically, enough child and adolescent psychiatrists. So now again, from a healthcare team perspective, how will we create healthcare teams to look at adolescent youth mental wellness and mental health? How do we ensure that it's okay to have the discussion with a young person in front of us about their mental health to begin with? I have 3 teenagers in my household. We were all teenagers once. And we know that it's very difficult for a teenage person to really let you know what is going on in their lives. So we have to create safe places for them. And we have to create the awareness that it's okay to talk about this, whether it be in the school settings, whether it be in clinical practice. We have to mobilize from a whole community of care about the importance of mental health and bring those necessary resources internally. But yes, we're looking at it. We have some pilots that are occurring with it. We do not have enough mental health providers for teens and adolescents, but we are working out ways on how we mobilize the resources we have in as well as a way that we can.
I just wanted to say a little bit more about this pilot project, possible pilot project with Dr. Fisher, because I think it's very, it is an example of how the transformation really is practical. If I understand this right, Dr. Fisher, who is a child psychiatrist that sees children in this area. She said that typically she sees like 20 children, adolescents in a 24-hour period or something like that, some number like that, and she needs to see that she needs to see each one of them so that she can bill for it, so that she gets paid. And under the old system, the fee-for-service system. And so she wants to have a global payment for her work. You can correct me whenever you need to. So that she gets paid for taking care of these 20, but she doesn't have to see them every month in order to get paid. Because a lot of them are getting along perfectly well. They don't need to be seen by the psychiatrist. Or they just need something that another person who is properly trained can take care of. So she ends up seeing maybe 5 or 6 youth and children who really need to see a psychiatrist that month, but the whole 20 are being looked after because of this team approach to care.
I'll just add one more thing, and that's the role of primary care. We're not specialists, but there are, once people stabilize, they can be managed in their primary care home, and the primary care physicians just want that person to call to help them manage it better. And I think that that's part of our challenge, is to think more broadly and realize that it's probably not always a specialist that needs to see the patient. Sometimes it's a specialist that needs to be the resource to the provider so they can stay in their medical home and be managed there.
I think just to clarify on the pilot, it's actually so that Dr. Fisher can see more children. So what's happening is that she can see all the ones that she normally sees, and then she's able to be a resource to the providers without actually seeing the patients, and give them the help they need, maybe the primary care, whomever, to take care of more patients. So it's not necessarily one about a payment thing in terms of the one she's seeing. It's really creating an opportunity and a different path so that she can consult with a primary care, a different provider, and give that psychiatric expertise to them without making the patient wait maybe a long time to see her. So it's really about broadening that pool. So it is pretty exciting.
What can be done to help people who do not want to come in because they heard they will be encouraged to lose weight, quit smoking, stop drinking?
So we know that in chronic disease models, over 50% of chronic disease has its roots in lifestyle choices. I cannot only do my part as a physician and say, you need to quit smoking. You need to not misuse alcohol, whatever it may be. I need to be willing enough to step back and meet the patient when they're ready to make the change. And that's a big, big mindset change for the medical community. Most of us are trained, and I thought, well, I've done my job. I've given the plan to the patient. I just expect that that should be carried out. Most of the time, it isn't carried out because 75% of what I just said to the patient in front of me was not understood by them. I talked in my medical language instead of living room language. And then, what they did retain, 50% was wrong. So how can I have a meaningful conversation about lifestyle changes and lifestyle choices when most of the information is just not retained during a medical visit? And again, I have to be willing enough to step back and wait and hand off to behaviorists that are in my healthcare team that can help encourage the patient, the person, in making their lifestyle choices and changes when they are most ready to make them. That will take time, but that's what the healthcare model is all about, with the utilization of behaviorists that are much more skilled in behavior change management than I am as a physician.
I'd just like to tell a story to kind of illustrate this. Some of you have heard me talk about Mary Jane and my son, brag about our son, actually, this in Alaska. But he tells this story to illustrate, I think, what Dr. Evanson is saying here, and that is comparing a baseball pitcher to another kind of model. A baseball pitcher can hit the target almost all the time with the baseball, because the baseball pitcher has practiced and gets so good at it. And in medicine, there are certain things that you can do that way. You can do that in emergency room care, sort of, because it's a set way of doing things. But when it comes to what we're talking about here, alcohol, tobacco, and all those weight loss and all those things that nobody wants to do anything about, he says it's like throwing a bird. No matter how much you practice, you can't throw the bird to where you want it to go, because the bird will go where the bird wants to go. We have a dog, we're dog sitting for it right now. I can use that dog as an illustration. But if you have something for that dog or that bird that they want out there, then they will go there. And so you have to find out what that person will respond to in order to do what you want them to do. Like in order to get the bird or the dog to go where you want it to go.
I'm sorry we're not going to be able to get to all of your questions because our time is kind of, winding down. But I'm going to maybe combine two of them here regarding the metrics. First of all, how did you get the information to come up with the percentages of improved access to care and patient satisfaction? In other words, where did those, the basic research come from? And also in that same line, what is being done differently that resulted in the 200% improvement in developmental screening?
So first, the metrics that the CCOs were given by the state of Oregon were brought forward by the Metrics and Scoring Committee that was set up by the Oregon Health Authority. And what they did is they looked at where evidence rested for certain guidelines, certain best practices, and they used as their resource the National Quality Forum. So it's important to understand that people just didn't make up these things that we've been measuring over the last year. They have their roots in evidence that it makes good sense from a wellness, a health perspective. When it comes to the access to care and the satisfaction of the care, it's really important to ask you all to help us in this regard, because this has everything to do with the patient satisfaction surveys that you may have received in your own home after you have been to a medical home. You may get something from Press Ganey or another vendor that mails out to you and wants to know how you felt about your current visit. That is a patient satisfaction survey. And all of that data was actually collected by a vendor, not the CCO. It was collected by a vendor based on our members' responses. It was only those members' responses if they took the time to fill out whether they were happy or not with their services. So that is the way that all the CCOs actually received their data, is from this patient satisfaction vendor that gave their data that was compiled and then given to the state and then given back to us. In terms of the developmental screening in the first 36 months of life, we've worked really, really hard with our partner clinics, our contracted providers, specifically family physicians and pediatricians. They're seeing these kids when they're first born and going through their first 3 years of development. We've really incentivized the use of a standardized tool. One of them is Ages and Stages questionnaire. And one of the tactics to improve the metric is to try to send out this questionnaire before mom or dad come in to the primary care office for their well child check. If it's done beforehand, we have a better chance of mom or dad sitting down in the living room and watching their toddler in front of them and filling out the form to see, are they rolling over at that time period? Are they crawling? Are they able to stack walks? And all of these developmental screens are standardized. So we've been able to improve our capture rate by trying to get clinics to send this out earlier before the well child visit occurs, because then they have a second attempt to then do it at the time. If mom or dad received it at home prior to the visit, but they forgot to bring it in, then it allows them to then do it real time in the office, and we've been able to improve our capture rate that way. I think this is going to be a really great opportunity for the future with our early learning hubs and how we align these developmental screens with the work that the early learning hubs are doing and that communication to our region, both the importance of developmental screenings in general. If we can catch something early in children, we have a much, much better chance of turning things around before they become that teen or that adult, where then the developmental delay has already occurred, much, much harder to then treat.
Thank you all, the panelists. Please give them a nice round of applause. Also, we want to thank our actors and all of our co-sponsors tonight. I've got just a couple more announcements to wrap up. Actually, Joe Zaire is here, and he wants to take just a moment to tell you about an opportunity to serve on the CAC.
This evening, Dr. Eby told you a little something about what the Community Advisory Council does and how it helps the CCO with its job of improving the health of the community. There are currently some vacancies on the CAC and on the local committees which support the CAC. If you are interested, or if you know somebody else who might be interested, please see me over here. I'll try to answer your questions as best I can, and if I don't discourage you too much, I will help you with the start of your application to either serve on the CAC or on one of the subcommittees. Thank you.
By the way, February 11th, mark your calendar, because we're going to be going to the Capitol in Salem and giving another try for this legislative session to introduce legislation to have a universal, accessible, publicly funded, real, seriously world-class healthcare system in Oregon. October 6th, in this room, a candidates forum about healthcare. Okay, we're going to have the would-be representatives for us, and we need to grill them real good about this. Then the February 11th date I already talked about. Thank you so much for coming, and give yourselves a hand, and we'll see you around.